So I want to emphasize one thing that Kevin mentioned. These are preliminary findings, but the database that I'm going to be showing you, or the database that generated the findings, has been scrubbed, and it's a closed database. So for example, we removed any patient who was in the Medicaid program but was in a long-term care facility, because even though there is a benefit within the bundled amount that the long-term care facility receives from Medicaid, we did not have codes. We did not have dental treatment codes. We had to exclude that population. So these are preliminary findings. We simply have not asked all the questions that we need answers to. So let me talk first a little bit about demographics. You can see that the final cohort size after scrubbing was over 500,000 individuals, and the age distribution between 40 and 64. So the average age is roughly mid-50s. As you look to the upper right, as you can see in terms of race, this is a very multi-ethnic, heterogeneous population. You can see the highest percentage are defined as whites, followed by Hispanics, blacks, and then Asians. And then lastly, on the lower part of the right slide, just on the right side of the slide, you can see, and not surprisingly, that females are a larger percentage of the population than our males. Kevin alluded to the fact that one of the boundaries of our study was the implementation of managed care for the Medicaid program, and about 95% of the individuals in our database were in managed care. Now, the graph to the right is actually quite interesting. The horizontal axis indicates those sections of New York State as defined by the Medicaid program. And as you can see, the vast majority, 70% of the population that we're going to be studying and as part of the Medicaid program reside in New York City. So New York City is driving a great deal of this. Kevin talked about the CRG methodology, which the Medicaid program uses to categorize patients in terms of their medical status. Each of these has subcategories. And the data that we can obtain from the CRG data is that grouping is dependent upon the ICD-9 code for our cohort, because ICD-9 was what was in effect, as well as the medical services and pharmacy that was required. And I draw your attention to the 5th and 6th lines, where you can see single dominant diseases of moderate chronic disease and chronic diseases in multiple organ systems. So about 60% of the patients in this 500+ thousand cohort have chronic disease. This is an ill population. Also to give you some indication of the nature of the population, they are financially insecure. More than a quarter receive supplemental SSI income, and more than a third receive cash assistance from the state. So as Kevin said, this is even a subset of the larger Medicaid population. Now, the utilization of dental services, and again, we're going to talk a little bit about, in the beginning of this, as I present the data now, about the first year of the study, 2012 to 2013. We're obviously much more interested in the longitudinal aspect, and that will be the end of the presentation. But look at the distribution of services for this reference here. 0.02% of the population had periodontal surgery. Root planing and scaling, only about 2.2% of the population, though they were eligible for it, and though we know they have a lot of periodontal disease, only 2.2% received that therapy. Nearly 9% received an extraction. And then restoration was about 16%, and preventive care was a little bit more than a quarter. So when we saw this data, especially the extraction data, we felt that we couldn't analyze this comprehensively. We couldn't just report on preventive care, but we also had to take into account the individuals or the circumstances in which people had severe dental disease, those that required an extraction or those that required endodontic therapy. So before I show you some of our specific data slides, I just want to make sure you understand the variables that I'm going to be talking about. So there are really three categories. First are the outcomes. As Kevin alluded to, we're going to look at rates of ED use, emergency department use, as well as rates of hospitalizations. Costs, we're going to look at two sort of summations of costs. One would be combined ED, hospital, and RX, pharmacy, and then would be total costs. So those would be the outcomes. And we're going to look at all of the entire population, and at the very end, I'll show you some data for those with chronic disease. Dental services, again, we're going to look at this balance between preventive care and what we're calling AI, anti-infective therapy. It's just our terminology, which means extractions and endodontic therapy, and then the time. So I'll talk a little bit in the beginning about 2012, 2013, but spend a little bit more time, a little more focus on the longitudinal side of this. So here's, for this first year, here's the distribution of services in the categories that we created. So about 60% of the individuals did not access dental services in this 1 year. About 40% therefore did. And this agrees with data that I have from when I was at dental school at Columbia. We looked at the utilization of dental services in our catchment area, which is about 42%. So 28% of the 40, so a little bit more than, a little less than, I guess, three quarters, had a preventive visit, either periodontal maintenance or prophylaxis. And that was divided between 21% had preventive care without AI, did not require an extraction or endodontics, but 7% had preventive care, but also had AI. And then the last group was AI alone without any preventive care. So required an extraction or endodontic therapy, but did not have any preventive care. So here again, for the 2012-2013, this cross-sectional analysis, you can see the ED rates per 100 people. To the left and to the right was hospitalization rate per 100 people. The reference category is always to the left, and that's no dental. And as you can see, there was a decrease in ED visit rates for those that had any preventive care, or those that had preventive care but did not require an extraction or endodontic therapy. There also was however, there was a slight increase in ED visit rate or ED utilization for those that had PC with AI, and for those that only required an extraction, or only had an extraction or endodontic therapy, their rate was much, much higher. So that really fit with our hypothesis. The hospitalization data for this cross-sectional is virtually identical. You can see a reduction, actually, it differs a little bit in the third group, PC, preventive care with AI, but essentially the pattern is very, very similar. Again, this is just the cross-sectional data. Now here are the costs. To the left, we have the cost for ED use, hospitalization, and RX, and to the right, we have total healthcare costs. So you can see a reduction associated with any preventive care, with preventive care without AI. There was really no difference if you had preventive care and AI relative to the reference group. And then if you only had an extraction or endodontic therapy, the cost was actually higher. Now, the total healthcare costs in general was higher for anyone who used the dental service relative to the reference group. And the interesting thing about the Medicaid database and how the Medicaid program is established is there are many services in there that typically would not be in other types of healthcare. So we have begun to look into this, and most of the difference is driven by outpatient community services, mental health services, and then substance abuse services, which tend to be extremely, extremely expensive. But you'll see even that trend will change a little bit as I begin to look into begin to present the longitudinal data. So here is the longitudinal data. Again, it's the dental events or the dental access for years 1 and 2 relative to the outcomes in year 3. Set up exactly the same way, and you can see the patterns are starting to become even more obvious. So the reference group in terms of ED visits, 76, we see a decrease if you had any preventive care or preventive care and did not require an extraction or endodontic therapy. There was a slight increase if you had preventive care with an extraction or endodontic therapy, and a dramatic increase if you only had an extraction or endodontic therapy. A very similar pattern for hospitalization rates as well. Now here, in terms of costs, you can see a reduction associated with any preventive care or preventive care without the need for an extraction or endodontic therapy. No difference if you had preventive care and an extraction or endodontic therapy, and a dramatic increase or pronounced increase if you only had an extraction and endodontic therapy. And now when you look at total healthcare costs, we begin to see this sort of coming down a little bit over the 3 years, where we see some differences, but not nearly the differences. And again, this being accounted for by the nature of the Medicaid program and what's covered, including outpatient services, community services, mental health services, and substance abuse services. Now, here's the data that will show in terms of the dose-response effect. Now, it's not truly a dose-response. We're just using that terminology to describe what we saw. So the red line is hospitalization rate. The blue line is ED use. And this would be for years 1 and 2 relative to the outcomes in year 3. So the maximum number of visits, of preventive visits you could have had is 4. 2 per year were allowed. So you can see if you had none, 1, 2, 3, or 4 or more, and it's not important to go into why it's 4 or more, but 4, and you can clearly see this dose-response effect. As the number of visits increase, the utilization in terms of the ED, the emergency department, and hospitalizations decrease. Now, everything I've shown you so far is for the entire population. We have begun to look at the NCDs, obviously. Time doesn't allow me to present this in any detail, but here we're simply looking at those who are defined in the 4 NCD categories that we're looking at: cardiovascular disease, diabetes, respiratory disease, or cognitive impairment. Whether you had preventive care, here we're not putting anti-infective therapy into it yet, for years 1 and 2 relative to year 3. And in every case, you can see that those that had preventive care had lower rates of ED use and hospitalization, and their total health care cost. In this group, the total health care cost was actually lower for those that had PC versus those that didn't have PC. And that's probably driven by the fact that just care for the NCDs, just care as it occurs naturally, would be much higher. And again, it's interesting to see the numbers in the CVD group are greatest, followed by diabetes, respiratory, and cognitive impairment. In fact, that's an inverse relationship to the savings that we see and the relative increase or improvement that's associated with the use of preventive care. So what are the concluding remarks? The study is comprehensively examining the effect of dental treatment on health outcomes and costs. And you can, I think you see this. There are many, many questions that we still have to answer, in addition to defining in greater detail the NCD, what's happening in those subcategories of NCD. But our preliminary findings indicate that for the first 2 bullets, for everyone, reduced ED and hospitalization rates and reduced ED hospitalization and RX costs for the entire population. But for the NCDs, what we're seeing is reduced total health care costs relative for those with NCDs, for those that had preventive care. So one of the things that's different about our study is that we looked at this, we looked at this as a balance. It's not just about treatment, but it's also about the level of disease. Now, we don't have diagnostic codes, as everyone in this room, dentistry does not have diagnostic codes. However, so our surrogate for that is, or for the level of disease, was either endodontic therapy or tooth extraction. And we found that the need for anti-infective therapy, again, endodontic therapy and tooth extraction, reduced the benefit you saw with preventive care. Now, this does not prove causation. These studies and these databases don't allow causation to be determined. However, it certainly strengthens the case for biologic plausibility, and I think that's one of the real strengths here. We also saw, again, strengthening the case for the fact that this is a real finding, is the frequency of preventive care utilized. We saw this relationship, meaning as you use more care, the outcomes improved. So the analysis is continuing. Kevin and I have been speaking a little bit about this recently. We could go on and on and on with this database just virtually forever. But I have been looking at data now for many years, and I rarely have seen anything that quite as interesting and intriguing as what we presented today. I do have to make some acknowledgments. First, I want to thank the New York State Department of Health. Though we have a contract with them, the amount of in-kind support that they have provided is absolutely remarkable. We have routine calls on a every week or every 2 weeks with a large group at the New York State Department of Health, as well as Steve and Mike and myself. I should have mentioned that from the Santa Fe group. It's myself, Steve Abel, and Mike. We certainly want to I want to thank the Santa Fe group for their support, in particular the John Hartford Foundation, the DentaQuest Foundation, and we also certainly have to acknowledge the people who actually manage the data, Yi Zhao Zi, who is at the New York State Department of Health, and Bin Chang, who's a biostatistician at Columbia, and who I've worked with for many years. So I want to thank you for your attention, and I hope I haven't gone through this too quickly. We are very excited about this data, and I think there's more to come. Thank you.